We're going to talk about some cystic kidney diseases now. There's going to be an autosomal recessive polycystic kidney disease. We're actually going to talk about autosomal dominant polycystic kidney disease as well. So, first, the recessive one. This one is seen in fetus or infant. You get bilaterally enlarged cystic kidneys. This is what a polycystic kidney looks like. So there's a bunch of cysts, which are fluid-filled sacs. In this case, the kidney's it's already taken out, so there's no more fluid there. You see all these sacs in the kidney. To me, it's honestly disgusting, but I just have that fear of the holes. Anyways, the problem here is it's bilateral. Your kidneys aren't working, so you can get Potter sequence. What was Potter sequence again? Remember, your kidneys don't work. You get poor urine output. You get oligohydramnios. Then you get compression. So you get compression of the face, flat faces. You get compression of the limb deformities. And then the baby's not swallowing that amniotic fluid, so they get pulmonary hypoplasia because you need that pulmonary fluid to distend the alveoli. So that's it for a little review of Potter sequence. And later complications include hypertension, renal insufficiency. Okay, kidney's just not working because there's all these cysts here. You can imagine it's not going to be a very functional kidney here. Next, autosomal dominant polycystic kidney disease. This one presents you have microscopic cysts at birth, but they're so small they're not causing problems. But over decades, these tiny cysts will slowly enlarge, and then it's going to become more like this, and then these larger cysts are going to compress the renal parenchyma, then cause atrophy and fibrosis. So the kidney's going to stop functioning, but it's going to take time, okay? So often asymptomatic, but eventually you can imagine you're going to get compression of the renal parenchyma, it's going to hurt, and then you're going to get high blood pressure, you're going to get hematuria, and your kidney's not going to work very well. Okay, hematuria because these cysts can bleed, and the hypertension because your kidney is not working. Okay, next is the fact that you also get cysts in the liver, and this is also associated with cerebrobarry aneurysms. And the easiest way to remember this is just think of this as a cyst too. It's a dilation of a blood vessel, but in our minds we can think of it kind of like a cyst. So you get cyst in the liver, cyst in the cerebral arteries. You can get a Barry aneurysm. So the key thing to remember is that autosomal dominant one presents later in life. Autosomal recessive presents pretty much as a fetus or an infant, okay? And I want to throw back to another cystic problem that we had that I talked about in the embryology section. This was the multicystic dysplastic kidney. Do you remember what the pathophysiology of that one was, just for a review? Remember, in that one, we have the ureteric bud that forms, but it fails to induce differentiation of the metanephric mesenchyme. So instead of getting some nice differentiation, you get all this like connective tissue and cystic kidney that doesn't really work because it's not differentiated. I'm trying to draw that here. So that's the multicystic dysplastic kidney. And this was usually just one kidney, but if it's on both sides, then you really have to differentiate it from this autosomal recessive polycystic kidney disease, which is bilateral. Alright, we've talked about these cystic kidney diseases, so these are just diseases where you get a lot of cysts. Normal people who don't have these diseases can also get cysts. Okay, cysts are just fluid-filled sacs in the kidney, and they can develop for many reasons, including they could show up on imaging. And the really key thing is to differentiate these cysts from cancer. Okay, so you want to make sure that if you see this fluid-filled sac, you're not dealing with a cancer. To stratify the severity and the cancer risk, we can classify the cysts that we see on imaging into simple and complex cysts. Simple, as you can tell from the name, are basically smooth and thin walled. They have a nice simple oval shape. Okay, if it has a nice simple oval shape, it's a simple cyst. And there's minimal risk of malignancy. You just let it be. You just pretty much don't do anything with it because it's totally normal, not going to cause any problems. However, we have a complex cyst. Pretty much anything that doesn't look like this is a complex cyst, in my opinion. This does not look the same as a nice oval. Okay, this is not a nice oval. If you want to go into details, they can have, if you have septae, so just like stuff, like different walls dividing the cyst. If it enhances with contrast, so it lights up a little white. If it has calcifications, again, more whiting up. Or if it has solid components, all of this is not normal. All of this is not a nice, simple circle. And that makes you think a little bit harder about cancer, and you may need further workup. So that's it for a cyst in the kidney.